I'll let you kick it off.
All right. So I will keep an eye on kind of others that are coming in. But in the meantime, we will go ahead and get started. Pretty good group this morning. Thanks for all taking your time to join us. We have some things to share and even more, hopefully, looking forward to some good discussions with the group. I think there's at least one person that is new to the group, but I just got a note that will be listening in. So I'm not sure, Cassandra, if you're able to speak or not. If not, if you can just say hello and who you are in the chat for everybody, that would be great too.
Yeah. Can you hear me okay?
Yeah.
Awesome. Yeah, so I'm on my phone. I apologize, but I am Cassandra Knudsen. I believe I've attended one or two previous meetings quite a while ago. But I work at Iowa State Partnerships and Prevention Science Institute. We're just looking for, potential opportunities to continue collaboration. So thanks for the ad. Looking forward to it.
Excellent. Thank you for joining this morning. Anybody else that I might be missing here that might want to say hi to the group? It's been a while since you've joined or new to the group. Okay, I didn't think so, but just thought I would check on that. All right, Greg, I'm going to go ahead and hand it to you to run the slides. This will be our way to keep on top of the agenda for everybody.
Yeah, I just thought I'd build on a few points, even though what Cassandra mentioned. So these meetings are really a great fit between what our U-Turn group has been working towards for many years and what the hub does. So that's why we have both logos there. And so there's many of us on our ISU Translational Research Network that are joining these calls because we share the same goal of disseminating evidence-based programs in practice through the hub. And so it's a really great fit that we can bring some science and research capabilities and training along with what the hub architecture already enables. So this is a really key part of our hub efforts. And so, but PPSI is the Partnership for Prevention Science Institute, and our U-Turn team, including in particular Ashley Scudder, both help lead that or work with that group. And we sort of view that U-Turn kind of could live under the PPSI umbrella because U-Turn is really just a network. But PPSI is an institute. And so on our last grant, which we just submitted, and you'll hear a little bit about, we actually partnered directly with PPSI, and we envision that that's a really strong potential for the future because they bring a very robust infrastructure for us to do research through the hub. So I just thought I'd add that, Ashley and Cassandra. So just as a summary for all of you, we've covered this before, but the general goals of the subcommittee are to facilitate collaborative grant writing, and we've had some nice successes in that front lately. Promoting quality assurance. So one of our goals with implementation science is to continually evaluate what we're doing. So anything we implement, we should evaluate, and anything we evaluate, we should implement really well. And so we view that we want to always focus on continuous quality improvement in our work, and in some of our grants will highlight how we're doing that and trying to build refinements over time, with somewhat the summer almost serving as a catch-up time where we can bring people together and say, how are we doing in our programming, and then move more into the academic calendars to continue our work. We also want to develop best practices for training and implementation and build capacity in community-based organizations. So we'll never really be able to fulfill the goals unless we can build capacity in the CBOs and also enhance our ability to capture that data through the hub. And so that's the last part, is creating standardized processes for delivery and evaluation. And so we're still working on all of these. So today's meeting will be kind of a, still we're in the early phases, I think, of trying to do all this as a collective team. But I think you'll see that we're building up nicely, and the things are progressing. So these were the general goals of the subcommittee, but then we also outlined these priority functions in setting up this group. And the first two are really central to our data tracking. And so we want to facilitate tracking and sharing of health data at state and county levels for ongoing surveillance. And so we have our BRFSS team joining us here today. We also want to continue to work towards enabling us to share this data out to drive interest and engagement And we have our extension partners from the Indicators Project, Chris Seeger here, and I hope Eliza and Chris, you can maybe comment a little bit later in the meeting about like where we're going with that or what the progress is. And you'll start seeing the potential, not just on the arthritis grant, but how we can use these same tools and same approaches to drive engagement in broader hub activities. So those are two functions of the subcommittee. Other ones, again, are focusing on fostering collaborative state and county partnerships on shared data and evaluation. And we want to do that with and through extension. So we have a couple extension leaders that are key to our team here. Promote adoption of data-driven screening tools to facilitate recruitment and referrals. And so we've been working on screening for fall prevention, I've highlighted before, and so that's still a key, but we want to also screen for physical inactivity and arthritis. And so we want to build these referral pathways that enable screening to happen and to drive referrals into the hub. And so we're still driving that. Also developing and evaluating training methods to build capacity in community-based organizations. So we're currently working on that. We'll highlight a little bit how we're starting to move that forward with our arthritis project. Katrina will share a little, and I'll talk about how we're doing that with Walk with Ease. And then this one gets more at this implementation science approach that ultimately we want to study what we're doing and use this RE-AIM framework to monitor our reach and efficacy. So how are we reaching out into the target populations we want to serve, and what's the efficacy of our program? So we have to build this system science approach into everything we do. So those are the 6 functions of the subcommittee that we've identified. There could be more, but that's just a reminder for all of us. I guess I forgot there's a 7th program evaluation and research needs for grants. So the other thing we'll do here today is we'll have brief summaries of different projects, and we'll also have summaries of future grants. And so one thing we wanted is this subcommittee to kind of serve to support ongoing research and evaluation so that we can have an infrastructure that we can be more competitive for grants. And I think we're already kind of hitting that tipping point here where the hub infrastructure is really helping us be successful in applying for grants. And that's really important for our ISU investigators on the call here. All right, so with that, I'll jump into kind of updates on these new grants. And so I think 2 months ago, we might have hinted at this opportunity for an R01 that's focused on health equity. And we were successful in getting that grant submitted. It was a fast push the last month to really get it done, but we're happy about that grant, and it is again very well aligned with what we're trying to do through the hub. And so this is the proposal. So the title was, well, it was an equity grant proposal, and we titled it Integrating Medical Care and Social Care Through a Community Care Hub Model, a feasibility study to reduce disparities in diabetes prevention. So it was targeted to NIDDK, and they care about diabetes in particular as one major chronic disease. And so we anchored it to strategies that we can use to enhance the DPP program that Trina and the hub are already kind of implementing. And we do that in partnership with the National Association of Chronic Disease Directors. So we had really great partnerships to pull this together. The figure is, maybe confusing to look at, but I'll highlight what we tried to do here. There's 3 specific aims. One was to implement enhanced social determinant of health screening practices through a community care hub model. And so we're doing that in partnership with the primary healthcare network, trying to implement better screening standards that would allow the clinicians just to do a simple screen using the Prepare, and then they would refer to the hub to do a more robust screening tool. And that was done through a program called the Gravity Project, or an initiative that we're trying to implement the very best equity-based standards for that. A second goal was to promote shared decision-making in screening and referrals to enhance enrollment. And so we proposed to do that through our motivational interviewing training platform that we've developed through U-Turn. And so that's another good case where our U-Turn team is working on the training side of things, trying to build capacity in community-based organizations and providers and staff to deliver motivational interviewing as part of their practice. And that is designed to promote shared decision making, which was a key target in the grant. It had a lot of very specific requirements, and I think we were successful in meeting those. The third one was to evaluate the feasibility of addressing an identified need, a social need, through a community referral. And so Trina already had a partnership in place with Capital City Fruit to partner to deliver food for those that have food insecurity. So these are the three components of equity. So we call them multi-level equity-based strategies, where we're working at the provider level, a staff and training level, and then also at the individual level to try to impact outcomes. So Trina or anyone else on the team want to comment further on that? Or?
I just would ask maybe Joy to very briefly, if you want to just share the Gravity Project
Sure.
Day standards. That I think that's very interesting. And then I will just mention the equity-based MI training. So we're taking the existing MI training infrastructure and great work done there, and bringing in some of our experts nationally and statewide. And Joy will mention in a moment about our Hub DEI Advisory Task Force and the strong representation we have there. They will be helping, including a community advisory board made up of members with lived experience from the communities, all putting input into the equity-based piece to integrate that with the MI training. And again, one of the strong partners, NACDD, has a health equity council, and the director over that is who's helping us initiate those things. So yep. Joy, do you have anything else on the Gravity Project maybe to add?
Yeah, well, for those that aren't familiar, Gravity Project is data standards and terminology around social determinants of health, which really didn't exist in the healthcare ecosystem. And they've developed a lot of standards and now are working with partners to implement those. So they've been doing 4 implementation project sites across the country. And so we've been in close conversation with them about being a future site and partnering on this grant. So they're fiscal agent of Civitas Networks for Health, which is a professional association for like health information exchanges. And so they provided a letter of support and will be working with us to, if the grant is awarded, figure out how we do this. And this is important to build towards interoperability, data exchange, so that we can actually exchange data in ways that'll be meaningful across multiple systems. Yep. Yeah, if you have any questions, or I can put a link to the Gravity Project in the chat for those that want to look at it.
We'll provide more details on this as we go. It's a major R01 grant, so these are very competitive. Obviously, we won't hear for about 6 months probably, but the suggestion, or the reason we are able to compete for this grant is because of this hub infrastructure and the partnerships that we have. So you'll notice the hub is central in here, that we're trying to enhance medical care and social care, and that's exactly what the program requested. And so I think we are very responsive in what was asked, and this shows the value of these community care hubs and why they're being valued at the national level. So it'll be great to get this feedback. And my only thought is, again, as a collective hub team and our research team, I think we should try to operationalize and move forward with as many of these ideas as we can between now and when we get our reviews back, because it's not typical to get funded on the very first try. With an R01, sometimes you have to resubmit. And so we have to be responsive to the first round of reviewer critiques as well. And so if we can start implementing some of this, Joy, and just move it forward a little bit with the Gravity Project, then if we get reasonable scores, we can say, well, we've already advanced this work and now we're really ready to go. So that's the kind of ongoing work we need to keep working towards.
And Greg, I just want to say one last thing. Is just, I need to just share that, we're very thankful for our partnership with PHC Primary Healthcare, the leadership of Dr. Andrew Bretson and his team, and then of course Iowa Primary Care Association, and looking at this possibility of a focused work with Primary Healthcare Central Iowa to start, but then being able to advance this work through the FQHCs in the state, hopefully, if we see these successes. So just want to share that we're very thankful for our healthcare partner.
Yeah, definitely. All right, so that's again, that helped to have that grant. And Trina wanted to bring up another opportunity, and so these are starting to all hit and be very synergistic. So she wanted to comment on this one and see if there's any traction to move this one forward.
Yeah, and I know that this particular committee, we're trying to bring together researchers. Obviously we have strong leadership through Iowa State, but I think Becky is also on here. We want to engage Iowa and their research team and others. So bringing in these research opportunities and seeing how it might fit with our teams in Iowa, our people in Iowa. And Greg, I think you'd be happy with this one. It's a rolling submission, so that we could give us some time.
Yeah.
and like the NIH, but we see this as something that is very similar to what we just put together for the NIH grant, obviously with some tweaks depending on the partners that might come together and some of their work that they've been focused on. But this is a rolling basis grant. I'm sure some of you have heard of these Evidence for Action through the Robert Wood Johnson Foundation. Grants that they have or funding opportunities that they have. This is geared towards studies about upstream causes of health inequities. It's particularly interested, and you can kind of see there's a theme here in strategies focused on developing healthy, equitable communities, and fostering alignment among healthcare, public health, social service systems. So it's bringing kind of all of the three systems together. And the what we've heard nationally is that is done or at least being researched to be done well through a community hub model. So that's what we would be looking at again. So again, it's similar to we think that it would be similar to our NIH submission. We have that infrastructure kind of outlined and the framework kind of built up. We would like to see, promoting that increased screening, shared decision making, bringing in a strong focus with CHWs, since that is a priority now in the state. Produce delivery, our concept with pairing that with evidence-based interventions, and we're doing little pockets of that now. In Montgomery County, we're talking about Wapello County now. We've got some others aligned that we're going to do pockets of this this pairing of produce and evidence-based interventions. And then we also, our partner HERDA, we wrote a grant, Community Connections grant. Unfortunately, we did not receive it. We thought we were kind of it would have been an outside chance of getting it, because I think they're more focused on built environments, and so we kind of fit but kind of didn't. But we have now the framework and the partnerships, that have come together to discuss this. So like a subsidized transit program for evidence-based interventions as well, potentially bringing in those two focuses of addressing social needs. So yeah, we're open to ideas on this. If people have some work already being done in this area, what partners we can pull together. But this is something that we feel that we have could have a really good chance at. Anybody have any thoughts or discussion points?
I have a thought. I don't know if it's very helpful, and I'm sure you're already aware of it. So having spent a considerable amount of my career on FERSA grant writing, it's challenging, and it can be challenging in Iowa to address racial equity simply by the nature of our demographics.
Yeah.
I do believe Iowa is ripe for this kind of work. We are evolving and changing, and our demographics are distinctly different from, when I moved here 30 years ago. So I think there's an opportunity, but I think you'd have to very carefully highlight the opportunity in Iowa. So anyway, that would be the one potential barrier I would see.
Paul, you bring up a really good point. And I think we try to address that with this NIH grant. And thankfully, we already have that partnership. But by working through the FQHCs, they have such a high, they serve a high patient population from those target populations that we want to serve, and through, obviously through these grants that's been why we are focused on the partnership with FQHCs and doing this work. And obviously, if we can do this work with their populations, hopefully then we can take it, statewide. But you make a really good point, and that is why I think, sometimes Iowa's not considered in some of these grants.
Yeah, the third bullet point about Robert Wood Johnson Foundation, I mean, that is exactly what I understand the hub to be doing. And I believe that the research around the hub is trying to better understand this and try to do it better. So I think if they focus on that component and the team is able to write to the racial equity benefit of that mission, then I think you're absolutely correct. It would be very competitive. Had this just said rural equity, I think you would be a killer applicant. It's my understanding that when we start to look at the distribution of different racial and ethnic groups in Iowa, they're very pocketed, and in our own efforts at Iowa Total Care, we found that if we focused on sub-demographic populations, that there are lots of political implications of that. I don't think you'd run into that kind of barrier, but anyway, your team is smart. You'll figure it out. But that would be the one thing I would be concerned about as a person who wants to bring this to Iowa.
Very good. Thank you. That's great feedback.
I guess our U-turn team has submitted for these E4A before, and they're challenging, and obviously, but I think we have the infrastructure here now. The rolling basis is both a challenge and a benefit and a curse, because it makes you not know when we're ready, right? So when are we fully ready? Because you really just get one shot at it. And so my suggestion is that we build some of the screening at the prepare and that gravity project infrastructure before we submit, not as a proposal that we're going to do it, because they really want to see that we have it. And so this would be a case where we should try to take some incremental steps, knowing that if we build that, then we can study it through this system. We also have to keep the NIH grant separate, because they don't want duplicative projects. So the NIH grant has to live on its own, but this could cover new ground and focus on the food insecurity and that piece in particular. So, I think anyone else on the call, I think there's great potential for this, but we just need to put a team together that's going to go after it. So maybe work through Trina and Joy on this one if you're interested.
Yeah, we're having a meeting next week, just a preliminary meeting, but once we start to have these conversations with people that might be interested, then we'll bring kind of people together. On Thursday, we were meeting with Capital City Fruit. They've been a great partner and always giving us letters of support, trying to support us in ideas, thinking about what they're already doing with the farmers and bringing more food in, and maybe using volunteers to get deliveries to homes. I mean, they're definitely an active partner in wanting to be part of any of this type of research anyway, focused on the health related social need of food insecurity. And then HERDA again is also another one. So yeah, if anybody is interested, please contact me. We'll start to have conversations and see what we can pull together, who we can pull together for a larger meeting.
So Lindy, in particular, if you know anyone in food science, or if you're interested, or if you think there's others that have been studying this from a food perspective in FSHN, maybe forward that to Trina or let her know if you're interested.
Okay, thanks. All
right, we can keep moving here. So we also wanted to highlight a couple of subcommittees that are also relevant and that harmonize with the hub here. And so this is kind of a new picture. So our implementation committee is down here in the lower right, but we wanted to highlight a little bit about the Data Safety Monitoring Board and the DEI Task Force. Trina, I don't know if you want to meet, I can briefly comment on the DSMB if you want, but then you could cover this. But the DSMB was somewhat built as a way to enable us to actually follow through on running these trials through the hub. And so forming it was a requirement really of running this randomized controlled trial that I'll talk about in a little bit. And it's been really helpful. So in our clinical trial on fall prevention, we actually had an adverse event of a person falling. The process for that is that we have to share that with the IRB, then it gets reviewed by the Data Safety Monitoring Board. The monitoring board evaluates the scenario of what happened, provides a summary report that then gets shared back with the CDC. So this is a requirement of running these types of large trials, and having the infrastructure in place for this is going to be really important for any researcher that wants to run projects through the hub. So I want to thank Paul and others on the team for taking the step to be on this board, because it's really critical for researchers. Paul, any thoughts on your observations of the board so far?
No, I think it's a great board. Trina would have to observe on whether we're functional and helpful or not. My initial impression is that I think it's a good board, and I think Trina does a great job, but I think we did actually provide some useful input. And I would agree. I think what the hub is doing and aspires to do is innovative and something many other groups aspire to do. And creating that subcommittee sets the stage for other projects that people want to dovetail with what the hub is trying to do. So yeah, I think it's a great step, and I'm hopeful that you, Greg, and Trina find the input from the committee helpful.
Yeah, that's great to have it operational, and that's again going to be key for any researcher that wants to submit a project through the hub. In fact, you have to have your protocols technically reviewed by a DSMB before it goes and is registered with IRB and clinical trials. So, we can start sharing those guidelines for other researchers that want to do work through the hub. So,
and all I was going to mention, and so absolutely feel that way. It's been very helpful to have the guidance, especially even just drafting some of these original documents that we were having to do. So very thankful for that. I was just going to mention that I attached the approved hub charter for the Data Safety and Monitoring Board. So hopefully everybody maybe gets a chance to look at that. And that's all I was going to mention, Greg. And I think I actually have Joy speaking about the Hub DEI advisory task force.
Yeah, thanks, Trina. So last year we had the opportunity to participate in the Administrative Community Living's learning community for hubs. And one of the things they really emphasized was adding a DEI advisory task board. And we'd already had that in the pipeline, and it just seemed like the right time as we add the Data Safety and Monitoring Board to formalize that and really focus on more lived experience and feedback from diverse perspectives. So Trina did a great job recruiting lots of different folks from different backgrounds and different, lived experience with disability, individuals who are BIPOC, to meet together and kick off the DEI advisory task force. And it was a great meeting. We're working on a charter that we've asked them. They really wanted to provide feedback and give it to be thoughtful and engage that group. So we're hoping that we'll be having a chair and co-chair step up and lead in that group. But it was a really engaging group. They're really excited to provide feedback, and we're excited to move forward with that. And I just think overall, I think Greg and Trini have already mentioned, it's just the structure that we're getting in the hub, and formalizing a lot of this allows us to really advance forward. For example, Robert Johnson Foundation, you're going to need lived experience. You're going to need these advisory boards, and the commitment of the people in the community also to give us great feedback so that we can be working towards health equity and other sorts of equity is really important. So anything you want to add there, Trina?
Well, I think you did a great job.
Okay. Just a note, that group will be meeting quarterly. And again, once we have some of that charter and stuff, we can share that. I'd also say if you have individuals that you think would want to join too, we'd be open to adding other folks that might be interested.
Yep. All right, good. We'll keep going here. I'm going to try to speed up to keep us on track here, but the goal of these meetings is eventually to have brief updates from these different projects, and I'm going to fly through a couple of mine and maybe leave more time for Lindy to build on hers, or maybe we just need 2 minutes on each one. But over time, we're going to highlight progress on these projects. So this is the fall prevention trial that we've been leading here at ISU in collaboration with the Hub. So we've formally run it through the Hub kind of for this AIM 3 goal, really, because we want to study the dissemination elements, but This is our randomized controlled trial where we're enrolling people into a fall prevention study. They either get a standard exercise prescription or enhanced, and they also get stratified to 2 types of behavioral training. And so the 2x2 design will help us understand the value of different exercise prescriptions and different training. We're currently in year 2. We're kind of run cohorts every semester. We're a little behind in recruitment. We really only have about 20 in progress right now, and our target for the end of the year 3 is 240. So we've got some work to do, but we're ramping up and adding a 3rd site, and I think we're building capacity to identify individuals at risk of falls. We're ramping up our training of student exercise leaders, so it's sort of our task of building capacity in our own system to have enough programs and people available to run them. But yeah, we're making good progress, and I'll share more later. Our state arthritis grant is the one we're really focusing a lot on now. So we just had our meeting with the CDC at the CDC. So I was in Atlanta with a new project manager that works with me, Abby Caniglio, and also Trina was online listening in on most of this. But both of these grants have a strong CDC oversight. So I was going to highlight that it's really good for us to learn like what their needs are. And so these 2 projects in combination with Lindy's will teach us what we need to do to really satisfy the CDC model. But you'll see that the hub is central to everything we're doing. And we put this team-based structure in place. And I wanted to highlight this because we are really excited about the possibility of this team structure serving multiple projects. And so ultimately, instead of there being project updates, we can have updates from the leaders of these teams. And so our progress since the last call was that we've had meetings with each of these sub teams, the referral team, the connector team, the ABBY coordination team, and the delivery organization. We also have an evaluation team and a marketing team. So we've had meetings with all of these, and over time, we'll eventually hope that these teams can harmonize their work so that we're serving not just arthritis, but also diabetes and fall risks and any type of implementation we're interested in. So our work now is we're trying to follow through our model for key priorities in our action plan. And so one is to do a landscape analysis of all the available ABBYs in the state. And so we're going to initiate that and are going to need any and all help from you guys to help us reach extension leaders across the state, AAA offices across the state, YMCAs across the state. So we're going to need to figure out where the programs are available, what the barriers are and needs are. And then again, continue to build capacity for training and referrals and awareness. So that's all I was going to say there. I might save time. I have a little bit more that we could talk about here, but I think I'd rather save time and maybe get to that at the end. So any updates from Trina or anyone on our team here about where we're at with the project?
No updates. Just want to mention that we're also applying for an NACDD arthritis, and it's also partnered with CDC arthritis demonstration project pilot.
Yeah, I'll bring them there then. This is a piece of, so let me just go there with this. So this is what our logic model was, and we had these 4 different components working through these teams. At the state meeting, this is a web link, and you guys could go to the Arthritis Council and these other resources to learn about what happened at our meeting. The one thing I was going to highlight is at the meeting, they're emphasizing the use of a arthritis care model that's now the national model for arthritis care. And this is an early depiction of the model. It's not the final one, but I wanted to show this because the process of screening and referrals through a community hub is exactly what we're doing. So we're really well positioned to basically follow the national recommendations for arthritis care. In fact, it's almost like they couldn't have written it better for us, because this is exactly what we're doing with referrals through a community health worker or a health coach and bi-directional feedback back to the hub. So there's very few states or entities that are really as well positioned as we are. And so we were encouraged to submit a grant to this demonstration project. So here you go, Trina, you can build more.
No, that's great. So so we are applying for that. We're encouraged to apply. It's actually open to only the grantees of component A and component B grantees, despite being only a Component A grantee, which means this is the first time we're receiving the funding, they've mentioned a few times that they consider us at the Component B level of this kind of work. And so that's encouraging, and it's encouraging that they've asked us to apply. So we have to apply with our healthcare partners. So again, we listed the support from primary healthcare, Dr. Ange Brentzman and his team, and the FQHCs to go along with this, and to really work on implementing kind of the arthritis care model that Greg just showed about bringing in more of the screening process, using some of their tools, the PAVs, some other assessments, and then the counseling piece, kind of practicing some of those things, having the providers, champions that we have within that group do some of this work, get the referral over. So working on all that implementation. So Greg, this will actually spread into the NIH grant work that we're talking about. So the infrastructure rebuild with the referrals, and integrating with any EHR and things like that. That's all the components that we'll be working with them through. If we were to receive this demonstration project, that would help us.
Yeah,
also.
that'd be great. So that just shows you again, we have this increased capacity. So Lindy, I was gonna let you maybe comment on your LEAP project.
I do. I want to go back to that NACD thing. But if you go back to that last slide,
Let me see if I can get there.
and anyway, what you're proposing in there, I think that's critically important for the hub is increased healthcare provider referrals. The hub needs to become a clear partner in the clinical enterprise. I'll be honest, I think it needs to expand ultimately beyond the FQHCs and the rural.
Oh, it will, yeah. This is just an example. They just want one pilot site to really test this arthritis care model, but as Trina said, it would build capacity for referrals of all types.
Yes, no, here's where I'm going with this. Okay, so I think this is really important potentially, but I would use it to get the big players. How you describe the pilot, but this should be some part of a marketing strategy to Unity Point, to Mercy One, to UIHC, to McFarland Clinic.
Yeah.
Somehow to get in front of the orthopedist, to somehow get in front of the rheumatologist.
Mm-hmm.
And because this is where the longevity revenue stream comes from.
All right.
So I think what I've always thought was really exciting about the hub project was this opportunity to tap into payment programs that covered community-based, evidence-based interventions and create a stream that actually supported these and was good for the patients. In this case, you could even go grandiose and say the people of Iowa. But it doesn't, none of this works if you don't start getting people to refer to you.
Yeah.
And so this little thing right here, that increased healthcare provider referral bullet point, from my point of view, is really important, and finding some strategy to do that. Because once they start referring for ABIs, someone will say, well, let's start using them to refer for DPP. And somebody will say they need a fall assessment. Let's refer to them for that. And then, all the opportunities around organizing communities. So anyway, A, this is very exciting. B, if you get it, use it if you can, if it provides adequate resources to get the big, everything is about Unity Point, Mercy One, and University of Iowa, as far as I can tell, for the most part. So
we're hoping
people to start sending you their patients.
we're hoping this leads, Paul, to exactly what you're saying, healthcare payment contracting or
Yeah,
healthcare contracting.
Paul, I could use your help in.
Right on.
Yeah. I was going to say, we're going to work on this with McFarland already, so you can help me. I do have those types of meetings in the near future with CMOs and the leaders there, so you can maybe help me make the case that we think we can. It does. First of all, I was going to say this pilot really doesn't provide any funding to the hub. It provides a little bit of mini support, but guidance to the healthcare system. So it's really a capacity building project. So they're getting support and care and help in moving this model forward, and we would all collectively benefit. So it's not really a fundable, or there's not like money in it for us, but it's a capacity.
There's a little tiny bit, Greg. There's like 25K. It's very minor.
That goes to the healthcare system. Yeah.
Yeah, that's what I was trying to say to the healthcare partner.
Yeah.
Very good. Anyway, that was my only.
Yay! I love that.
So Lindy, how about any updates on LEAP? I know you're still building, but I wanted people to remember that you talked about this 2 months ago and see where you're at.
Yeah, thanks, Greg. I appreciate the time to share. So just a reminder for everyone, Iowa has a CDC-funded cooperative agreement for the high obesity program, which is a previously funded program that funds states with states to implement evidence-based policy system and environmental change strategies in counties with an obesity rate of 40% or greater. And Iowa was able to receive the funding this year because we have a couple counties that are eligible to participate. And you can see here on this slide what counties are participating here in Iowa. And as Greg put on the slide, this is a capacity building project. So this first year, we're really working on getting our counties to build partnerships and coalitions within their county to be able to implement those policy system and environmental change strategies at the county level. So right now, what we're really doing, again, is building that capacity at the county level, working with our county extension leads in each of those counties to put together those coalitions in order to implement these activities. And then we're also at the same time doing a variety of needs assessments at the county level. CDC is very specific in what they want to see implemented. So they want to see implementation of specific nutrition strategies, one of those being around promoting the procurement of healthy food through implementing food service and nutrition guidelines in community organizations within the county, as well as increasing and expanding the use of fruit and vegetable voucher programs, things like double up food bucks and produce prescription programs at the county level, as well as increasing access to safe spaces for physical activity. So we're doing needs assessments around those particular areas, things like healthy food retail assessment, assessing if they have any of those fruit and vegetable voucher programs in their county, doing active communities toolkit modules to assess physical activity, safe spaces for physical activity in those counties. So that's all going on right now, or getting started on doing that in addition to building those partnerships at the county level. And then we're also working at the state level with some of you on this call, other organizations to provide overall guidance on the work we're doing. And like I said, this is a cooperative agreement with CDC, so they've been very hands-on already. This is the first month of this project, but we've been getting very specific directions from them as well. So I feel like there's a lot going on. I would feel like, Greg, you could just pull back up your CDC arthritis grant slide, and we're doing very similar things to what you're doing for that project right now. But I appreciate the time to provide updates, and I'll continue to do so, and even at times try to probably pull some information or thoughts from this group as well. So
basically, yeah, our vision would be that some of these same teams would be involved in harmonizing the work with and through the hub. So whatever you need, coordination through the hub could be done through those teams in red. So let's keep moving. So there's a couple steps here about community onboarding, but Trina, I might skip through this really quickly because I want to leave time for the BRFSS and decision makers. But this is a ongoing effort to build a system for getting community-based organizations and leaders that want to deliver evidence-based programs to opt into the hub, to get access to our services, to get access to training, and then to drive their programming through the hub. And so it's an integrated smart sheet form that'll eventually help us to track all these correspondence and manage them very effectively. But I think I'd rather keep moving, Trina, if that's okay with you.
They can read this afterwards.
Yep. And so we will send this out to some of you about how we're operationalizing this and how it'll drive training. And so maybe that'll be a good topic for our next call. But I wanted to maybe get a little bit of discussion on some of these evaluation strategies, because they're going to be central for our arthritis project and as Lindy's describing for her project. So one of the key things, and Eliza and Chris, I'll have you maybe share a little bit, but at the CDC meeting, they provided this resource to us, and you guys could use your fancy QR codes if you'd like, but there's a separate, I'll take you to this one, but there's a BRFSS statistical brief that talks about how we should be using the core arthritis measures. And I know you guys know all this, but the BRFSS team, but it's good for our whole team to fully understand the capabilities of that data system and how we could use it to capture data in individual counties. And I'm really excited about this for a number of reasons. For one, in our arthritis grant, we need to be targeting specific rural populations. And so the ability of BRFSS to help us identify which counties are rural and which ones are not is really important. And then the goal would be to start seeing if we are targeting those counties that have greatest needs, and if we're delivering more programming there, we should see more outcomes or changes in those counties than across the state as a whole. So rather than looking at the state tracking level, I'd love to be able to build towards a county level analyses of what's happening with arthritis programming and outcomes at the county level. So even I can take you briefly to this link here, but this is the BRFSS statistical brief. Eliza, I don't know if you've seen this, but it's available to everyone there, but it talks about how it links to what we're supposed to be doing in our project, and some of these, why doctor diagnosed arthritis is key, and what these codes are in your SAS code. So you can tell this is written for the BRFSS person about what codes are available for you to do all this work. So I wanted to make sure you and Olivia had access to this file.
Yeah, CDCR partners there are really great about providing those statistical briefs. I put a link in the chat for the other ones that they provide, just in case there are modules that other folks might be interested in. Olivia was able to join. I don't know if you want to mention anything more to this, Olivia, but.
Yeah, I'm not sure what additional things to say. These are, I'm an epidemiologist for the Iowa Purpose program. And yeah, these are just really helpful to understand the different modules and how they are intended to be used by analysts. So I provided some data for Greg in the application process for this grant. So the variables that you see in here are the variables that I would have provided to Greg and his team.
Yep. So yeah, I just wanted people to realize the scope and the sophistication of this, but these would be questions that we are required to use in our as performance measures in our project. And so what we're also tasked with, and I mentioned this to our evaluation team, is between now and December to actually operationalize what we proposed in our project as strategies for capturing these data into an actual plan. And so our next step, and our evaluation team will be meeting on this to now try to describe how and when we would use these data, how it would be used, how it would be fed back into the system. So what we proposed is just some strategies. Now they're tasking us with actually creating a plan. And I really like that in a way, because it does hold us accountable to move forward and like really operationalize our ideas. And so I think it'll be a formative step for us to take. And so I'll reach out to our evaluation team and we'll kind of dig into this a little bit more. But I wanted everyone to kind of see that brief there. Any other thoughts, Eliza or Olivia, on the BRFSS or updates, or else we can have you guys share maybe a little more details in the next meeting. And again, at some point, I'd love for the same data to be used to help Lindy track diabetes and obesity patterns in these 6 targeted counties compared to the other counties as well. So we can start learning from that.
Yeah, I guess just other updates for this group. We're currently in the midst of planning for our 2024 questionnaire. For those who don't have a lot of familiarity with BRFSS, we do telephone interviews January through December on an annual basis, collecting a lot of information on various public health topics, some of them being arthritis. So our partnership with this grant will be incorporating some arthritis specific questions. So just in planning out, what all we'll be having on our survey for the upcoming year, there was a specific measure related to arthritis with healthcare providers that we'll be incorporating into that 2024 questionnaire. So we have that in our plans. So we'll be collecting that data starting next year.
Great. Yeah, that'll be helpful. So yeah, I think I'll set up a meeting with you guys soon here, Eliza. The other link, I thought, Chris, this might be a good segue for you, is this, they also shared this new data source called Places, and you're going to like this when you see it, but you notice it's like linked to Robert Wood Johnson and the CDC about its model-based population level analysis and community estimates of health measures to all counties in the country. So it kind of builds on the county health rankings, but in a more sophisticated way. And I believe all this data is available as well, Chris. So here's a source that you could maybe dig into if you didn't see this. Any thoughts on your end, Chris?
Yeah, I think we have, for our rural areas, though, we're going to have some problems because
Yep.
It doesn't go deep enough.
Sure.
But it has still benefit to the state, because
Right.
as a state, the few points we do have, you can get a sense how are they comparing as a rural state, but it's not comprehensive at this point. I think it's something to keep watching, and that we need to keep being advocates of that. These are great tools, but can we get to a little bit more granularity in the populations in which it provides data? So and that's gonna be on us. We need to let them know we love it, but we need to see that more of it.
Yeah, I'll just add on to what Chris says. I feel like Olivia and I, whenever we see places come up, we always add the caveat that for Iowa, since it's provides model-based estimates, it's not always great for some of our more rural areas, exactly like Chris said. So yeah, it's a great resource, especially for our more like metropolitan areas, but for the rural zones of the state, just that caveat's important to share. So,
but honestly, Greg, that's also part of the reason why we need to be doing what we're doing in grants such as this on arthritis or on anything else, because they aren't reaching that level.
Yeah.
And
exactly.
so this is kind of proof of why all this work is really important.
So again, I wanted Chris and the team here to share. So the great part about the collaboration here and through this subcommittee is that we're going to build capacity to do this for arthritis, and then again expand that to enable us to share data back out on other things. So at some point, or Chris, I don't know if you have a chance even to drop the data for decision makers link in the chat, because others of you should really check that tool out. It's a really powerful tool that captures all this data and puts it into a form that a county health leader or extension leader could use. So it's driven through extension, and it helps give data for decision makers on what we need to do, what are gaps. And so Chris can take this data, put it into a usable form, and not many states have that capability. So we're excited to put that into practice here in our projects.
I'll drop in there right now. Just scroll down on the page I dropped in to the chat here.
Yeah, this is the final slide I had about one of how we've worked with the BRFSS team on this. So this shows some of the current diagnosis of arthritis, and Eliza and Olivia helped us get this data, but the statewide levels, for example, of that diagnosis is a certain level in the state, but it's higher in these rural populations. So that shows the disparity we're trying to address. Doctor counseling for activity, it's higher in medium and metro areas, and it's lower in the rural population. So that's another gap that we're trying to fill. And so as our team starts working on our arthritis grant, and this is for all of us that are on this group. There's many of you that we need help with. Liz, we haven't been able to pull you in, but your goal of reaching those that need it the most, we could really use help in figuring out how do we reach them most effectively. And then our extension partners could harmonize with you on how we target those county extension offices where we have the biggest gaps. But any thoughts on that from anyone? I guess we can leave it for discussion a few minutes here. Liz or Dawn or anyone else have thoughts on reaching just rural populations? Any thoughts in general? We have a couple minutes left. I just wanted to finish on time and make sure we got through the whole agenda, but hopefully you found value in the discussions today and we can see where that leads us for our next call.
Yeah, I had a phone call last week with a group of people that included some county public health department leaders. And a long time ago, I was an advisor to the Keokuk County Public Health Department, which I think consisted of 3 people. And their primary business was home health. And that one person who ran that public health department was the health expert for the whole county and would beyond. And that would be a potential source of people in my mind.
Yeah, that's perfect.
To get, there's somebody out there who's working for the county who people look to for expertise in some of these rural counties. And it's certainly how it was in Keokuk County. In my experience, so that would be a potential resource to the more rural need.
So that one thought there, Paul, and that's exactly the type of engagement we're hoping all of you can provide. Is if you have that kind of contact, maybe forward a little bit of info to Trina or I, and then we can help build on that further, or help you connect to other extension leaders through our network here or through our health department. So. All of us have these tentacles out to different populations, but to the extent possible, share it back with the hub. And so maybe, Trina, we need a group email, like a list that people could put so that they're reaching all of us on this subcommittee with a single email, because otherwise they don't know how to reach us individually, but that's an idea.
Yeah. Yep, that sounds good. We're just don't want to take too much time on this, but we're looking at creating kind of a forum for some of these communications for different groups, but then also bringing groups together. So that'll be definitely a part of that. But we've done Google sharing docs and things like that we can create a file or folder for this group.
All right, I guess since it's the top of the hour here, I think we can close. But I'm going to take the liberty of freeing you guys all up from a Christmas meeting on December 22nd. So I think we can just cancel that one, Trina, and let people have a normal Christmas holiday, and we'll resume in February with a follow-up meeting. A lot is going to happen in between, but I don't think we need to meet on December 22nd. So
that makes sense.
All right. Thanks everyone.
Thank you.
Bye.